Welcome everyone to this special webinar. The first scientific evidence showing how tuberculosis impacts lives of people living with HIV came in 1983. I repeat, 1983, almost 34 years back, when out of 20 among the first group of people living with HIV in the world, 12 developed tuberculosis. TB is preventable and curable, but the ground reality is that it continues to be the biggest killer among people living with HIV. TB is also the biggest infectious disease killer in the world, regardless of the HIV status of the person. This is unacceptable. I remember in an interview given to CNS in 2009 in Rio de Janeiro at the third Stop TB Partners Forum, Michelle Sidby of UNAIDS had said, "When a bacteria and a virus can work so well together, why can't we?" Sadly, his words ring true even today. Let us hope governments and all of us united are able to deliver on the promise to end TB as well as HIV/AIDS by 2030, as envisaged in the Sustainable Development Goals. And yes, when the HIV virus and TB bacteria can work together, why cannot we join forces to upstage them? That, my dear friends, is the moot question. Without any further ado, let me welcome today's webinar moderator, Ashok Ramswarup, who is a widely acclaimed international award-winning journalist based in Durban, South Africa, with over 40 years of rich experience in journalism. He was the senior producer at South African Broadcasting Corporation, or SABC. Over to you, Ashok.
Thank you, Madam G. That was our senior managing editor, CNS. Warm greetings from Durban, South Africa, a country which has seen heart-wrenching impact of HIV as well as TB and drug-resistant forms of TB. But South Africa has also seen positive examples of human resilience and courage in fighting AIDS and TB both. In lead up to World AIDS Day 2017, it is important to review that despite strong scientific evidence-backed policies and programs, we are still failing to avert every TB-related death among people living with HIV. TB continues to be the lead killer of PLHIV. According to the latest World Health Organization Global Tuberculosis Report 2017, 374,000 TB-related deaths were among PLHIV in 2016. Of the almost 500,000 reported cases of HIV-associated TB, 15% were not on antiretroviral therapy as recommended by WHO. TB preventive treatment is expanding among PLHIV, but most people eligible for TB preventative treatment are not accessing it. In 2016, an estimated 10.4 million people fell ill with TB in 2016. 10% were PLHIV. Out of these, 74 were in Africa. According to the World Health Organization, the risk of developing TB is estimated to be between 16 to 27 times greater in PLHIV than among those without HIV infection. Let us know more about our distinguished panel of experts who will give us a better insight of the issues affecting the population. Dr. Linda Gail Becker, President of International AIDS Society and Professor of Medicine and Deputy Director, Desmond Tutu HIV Center, Institute of Infectious Disease and Molecular Medicine at the University of Cape Town, South Africa, Chief Operating Officer, Desmond Tutu HIV Foundation. Dr. Ishwar Gilada, President of AIDS Society of India, ASI, one of the first doctors who began HIV care when first case got diagnosed in 1986 in India, and founder, leader of People's Health Organization, WHO, and a die-hard AIDS campaigner. And Nomampondo Barnabas, a TB survivor and person living with HIV and civil society liaison officer, International Union Against Tuberculosis and Lung Disease, the union. Before we listen to our first panelist shortly, let me request you all to keep sending us your question either by using the chat function or raising virtual hand of the webinar tool. Keep sending the questions while panelists present. It's now over to Dr. Linda Gale Becker, President of International AIDS Society and Professor of Medicine and Deputy Director, Desmond Tutu HIV Center, Institute of Infectious Disease and Molecular Medicine, University of Cape Town, South Africa, Chief Operating Officer, Desmond Tutu HIV Foundation. It's over to you, Doctor.
Hi everyone. Sorry, I'm just checking that everyone can see my screen.
No, we can't see it now.
Can't see your screen.
Oh, I'm sorry. Okay. I think we might have lost the screen somehow. So I'll ask you, Shoba, to move the slide on for me. Is that okay?
Yes, I think we'll move the slides for you.
Very good.
Yes.
Okay, so hello everyone. It's a great pleasure to be with all of you. In our first screen, you'll see that I've described this as TB control in a sea of TB HIV, and I'd like to explore both upstream and downstream interventions in the next 7 to 8 minutes. So I do need to move quite quickly. On the second screen, second slide, really just won't spend a lot of time because I think both introductions have already described just how much tuberculosis there still is in the world and how much of it is linked to HIV. And I think it's important to note that 56% of the world's tuberculosis currently resides in 5 countries. And we should not also forget about multi-drug resistant TB, of which there were about 500,000 cases reported in 2016. The next slide, slide 3, reminds you that we have some very clear targets, and these first targets are our HIV targets. By 2020, we hope to have everybody in a 90% of the world's population tested for HIV, 90% of those who are positive on ARVs, and 90% of those virally suppressed. And those are ambitious targets. Moving to the next slide, you will see how, in fact, we are doing according to UNAIDS in 2016. Definitely in the part of the world where TB is very prevalent and that I'm representing today, you can see we've still got some way to go in getting to our 90-90-90 HIV targets. So that's, again, more for your information. Slide 5 just reminds you that we have, similarly, TB targets to reach. And as Shoba was saying, there are the SDG targets by 2030, and then there are the NTB targets by 2035. And you can see again, those are ambitious, and unless we all get very organized, we are not going to meet those targets. The next slide gives you a little more detail about the NTB strategy. And I think it's very important that you note that the deadline there again is 2025 for these global priority indicators. So that really I give you as background to what the world is hoping to achieve. In slide 7, I show you how we're doing in terms of tuberculosis worldwide to date. And again, this comes from the WHO Global Tuberculosis Report. And you've already heard that 10.4 million people fell ill with HIV in 2015, and almost 2 million people died. And you can see where the high multi-drug resistant TB countries are, and where the majority of those cases currently reside. I do want to point out, if you could just hit the next 4 buttons, that in the first world, you really do experience individualized epidemics. So in other words, small pockets of outbreaks with low force of infection. When you move to these high red areas, the force of infection is 5 to 10%, and you are much more in the setting of a generalized TB epidemic. So moving to slide 8, I really just wanted to remind you of the natural history of TB, where an individual goes from a susceptible point to being infected, which we call latent disease, where people may be infected with HIV, with TB. And then if they progress to active disease, which a small proportion of people do, then we describe them as having active tuberculosis requiring treatment. So just so you know that as background. In slide 9, I'm merely pointing out that not everybody who gets infected goes on to disease. And as you can see, it's about a 1 in 10 in a lifetime who go on to get TB that requires treatment, or TB disease. Turning now to Cape Town, where I thought it might be very interesting for the listeners to know that we report more tuberculosis in a single city in a year than the whole of the US, the United Kingdom, and large parts of Europe. So in those places where there are generalized TB epidemics like Cape Town, we really are still reporting a great deal of tuberculosis. We recently wrote a paper, and this is now in slide 11, that I'm happy to share with the listeners on the webinar, that compared 100 years of tuberculosis in New York with Cape Town. And you can see similar populations in New York in 1910 and now Cape Town in 2010. And when you move to slide 12, you can see over the last 100 years what happened to the TB epidemic in blue in New York. So there you see the blue dots, blue columns of what happened to TB in New York. And you can see it went from a generalized epidemic to a localized epidemic to an individualized epidemic in slide 13. Now I would like to superimpose the Cape Townian epidemic in red, and you can see that we have never left a generalized epidemic in Cape Town. We have always been in the grips of a generalized TB epidemic, and not everybody realizes that. And this is the kind of picture you see in those 5 top countries that are still in the grips of a TB epidemic. So what's different? Well, slide 15 describes that when you have a very high force of infection, such as we find in a place like Cape Town, then you have a much greater risk of TB disease occurring, and this kind of increased cycle of infection that leads to much more TB. So I want to show you in slide 16 the reality on the ground here in Cape Town. By the time a child enters school here in Cape Town, 1 in 5 will already have TB infection. By the time they sexually debut at age 15, 60% of them will have TB infection. And by the time they reach adulthood, they will almost all be TB infected. And you can imagine that then in the midst of an HIV epidemic, you really do see an incredible increase in the rates of TB HIV. So in slide 17, I portray that in cartoon, that when you have HIV superimposed on a generalized TB epidemic, you really do have a critical situation. So that's where we're sitting today. And slide 18 describes very nicely, on the one hand, the HIV negative epidemic in Cape Town. You can see high rates in children, dropping right off to adolescence, and then this upswing in adolescence. And then comparing that to the HIV positive population in Cape Town, this enormous group of young adults becoming TB diseased because of their HIV in the age group 19 to 40 or so. So I wanted to think about how we think about TB in our primary healthcare settings. And you see TB clinics are a good place to pick up HIV, and of course people accessing HIV care and antiretroviral clinics, again, a very good place to interact and screen for TB. So an important combination of integration that needs to be thought of. And of course, if we don't do that, we see missed opportunities, inherent delays, and loss to follow-up. So again, thinking this through in the primary healthcare setting is kind of a no-brainer, but I want you to think about how it almost seems unnatural to put HIV and TB services right alongside each other in slide 20. So it really is, I think, something for us to think about, integrating these services, and certainly WHO has instructed us that it's important we tackle the 3 I's, namely intensified case finding, INH prophylaxis, and infection control. And there are lots of advantages to test all TB suspects for HIV, to offer antiretrovirals without delay, and to streamline our services to provide both medications in differentiated service delivery, which reduces loss to follow-up and enhances adherence. Slide 22, I think I do want to again make the point that we need to screen efficiently for tuberculosis amongst those who are living with HIV, diagnose drug resistance, offer more treatment options for MDR-TB, and these TB treatments need to be compatible with antiretroviral therapy, and they need to be well tolerated and safe. In slide number 23 reviews some data from a review looking at integration of TB and HIV services. In the interest of time, I won't go into that in a great deal of detail, but just to say that definitely the world is thinking about this now, and we're trying to think what the models of integration should look like. And there is, models out there that we can look at for best practice. And slide 24 really just describes this particular model that is worth thinking about in more detail. Going back in slide 25 to our generalized epidemic here in Cape Town, I do want to just bring one other point home. And what you can see to the right of the graph in Cape Town is this huge upsurge of tuberculosis, which has been as a result of the HIV epidemic. But if you should take the HIV epidemic away, it's important to note we would still have a generalized TB epidemic. So that's a point I just really want to bring home, that this is not all HIV driven. HIV really just is a canary, if you like, pointing out that we have a severe TB epidemic still on our hands. Slide 26 makes the point that Cape Town has done every intervention on time throughout this 100 years. So this is not because of poor services or because we have not been responsive to innovation. And you can see everything that has been done in Cape Town over 50 years. I want to also show in slide 27 that whenever antibiotics against TB have been discovered, they have been applied here in Cape Town. So again, making the point, this is not because we haven't had access to good chemotherapy. And you can see in slide 28, this has had an impact on our mortality here. But we continue to find ourselves in slide 29 in the midst of a generalized epidemic. So what I would argue to all of the listeners is that this requires more than just treatment. This requires an upstream approach to think about how we interrupt TB transmission in our communities, and how do we think about that actually coming about. So when we think about diseased individuals, we definitely want to think seek, test, treat, and cure. But to get population control, we might need to think about more structural interventions. So again here, this infection model in slide 31, forcing us to think about upstream modalities. In slide 32, I want to remind you that TB transmission requires an infectious case, people who are susceptible to TB, and shared air. So people have to be sharing air, which really talks about ventilation. And if we think about the Wales-Riley equation, again, you want to think about the volume of shared air, the prevalence of TB cases, and the infectious quanta. And so, in similar vein, we want to think about reducing exposure, targeted case finding, and reducing infectiousness. So in slide 35, I do think it's important to think about shared air and where people are sharing air and where we can think about intervening. So we've raised the question of classrooms and shared air, and transport and shared air for other ways to think about TB control in the future. So I'm going to wind up now with three concluding slides. First of all, TB control. TB is still endemic and generalized in many parts of the world, and we need to tackle that. So primary prevention is something I want us to think about. Turn our attention further upstream to tackle transmission. We need to understand where TB is being transmitted, amongst whom and how, and that the transmission driver is often within the HIV negative population. Those who are living with HIV merely become really, if you like, the susceptibles who become TB HIV infected, but the HIV negative population drives this. Slide 37, we have to think about downstream interventions. More than 6 million cases, they need treatment, so we need earlier diagnosis, earlier chemical sterilization of those individuals, and sustained cure. We need to think about ways to enhance adherence, reduce TB drug resistance, and therefore realize the secondary prevention benefits. And lastly, slide 38, we need to think about innovation. Better understand aerobiology of TB, where and when to interrupt TB infection, improved massive active case finding, think about new drugs, better vaccines, more options for multi-drug resistant TB, and ways to prevent lung damage and improve outcomes. My last slide, I just want to say, in terms of TB HIV, we have a localized epidemic within our generalized epidemic, which occurs in people living with HIV. It's important to reduce mortality in that group, so intensify case finding, offer IPT or INH prophylactic therapy, reduce further contamination of susceptibles, have pragmatic co-location of treatment, and continue to do research on good models of integration. And I'll stop there and thank everyone on my unit who continue to do this work, and to the listeners. Thanks.
Thank you very much. That was Dr. Linda Gale Becker sharing your expert remarks. This was the perfect opportunity to listen from a lead expert from a country which has the highest TB burden in the world. That was also the pharmacy of the world, supplying 80 to 90% of medicine to fight AIDS and TB both. Well, let's get moving. Dr. Ishwar Gilada, President of AIDS Society of India, ASI, one of the first doctors who began HIV care when first case was diagnosed in 1986 in India, and founder leader of People's Health Organization, WHO. Welcome back, Dr. Gilada, to our webinar. Well, it's over to one of the leading experts, Dr. Ishwar Gilada.
Yeah, good evening and welcome to this webinar. I'm really glad that you have put me along with a very great personality, Linda Gale-Baker, not only because she is president of the International AIDS Society, but she is from South Africa. And we consider India and South Africa as twin brother sisters. We have been together in both the fights, whether tuberculosis or HIV, and also in the fight for the freedom. And we call India, whatever India could help South Africa is a help for the second freedom struggle. I don't know why my screen is blacked out, but am I audible?
Yes.
Yes.
Hello?
Yes,
Yeah, okay.
you could see your screen also. We can see your screen.
Yeah, I can see my screen now. Okay. Basically, I have been telling for a long time that if you are looking at only HIV, and people were saying initially that HIV is not that widespread, but we said that in HIV the major killer or major infection is tuberculosis. A person with HIV, if gets tuberculosis, will spread tuberculosis to others, may not spread HIV. HIV will be transmitted only through sex, but tuberculosis will be transmitted through air sharing. So people were not bothered initially, and we needed to demonstrate a lot of prevalence of tuberculosis in HIV patients, which went from 0.5% in 1988 to almost 20 to 30% around the 1990s, late 1990s. Basically, if you look at tuberculosis bacilli and HIV virus, they are at South Pole and North Pole. They are totally different, diagonally opposite. They walk to the equator and they try to ruin the human being. So it has been a very good catch line that if they can combine, why we can't combine? And if you look at their morphology, if you look at their behaviors, they're totally different. HIV is 100% preventable, but 0% untreatable. Treatable, but it's not curable. Tuberculosis is exactly opposite. Is 0% preventable because it is shared by air sharing, and it is 100% curable provided it is brought in time. And these kind of infections coexist mainly because of tuberculosis has been a neglected disease. And if we go by what has been shown by Linda Gale-Baker, that tuberculosis in New York is not New York per se. New York is representative of America and representative of all developed world. So there you are seeing tuberculosis has gone down to now there is only individualized epidemic. That's the reason probably that there has been not much research in tuberculosis. In last several years, almost 30 to 40 years, you are seeing only 2 new drugs coming in tuberculosis, bedaquiline and delamanid. But in HIV, if you see, because it has affected initially America, also Europe, and therefore there has been a lot of research, and we see already 24 molecules already in the market for the treatment, and another 30 in pipeline. So the entire world, particularly the developed countries in the world, they were negligent about those infections, those diseases which were more prevalent in developing countries, and tuberculosis is one of them. So India being number 2 in population, it is likely to be number 1, number 2, number 3, number 4 in many of the health issues. But in tuberculosis, it is by far surpassing China, and it is almost one-third to one-fourth of the tuberculosis burden. The major issues remain currently is MDR tuberculosis, XDR tuberculosis, MDR XDR HIV, and sometimes some patients have MDR XDR HIV and MDR XDR HIV tuberculosis together. Now, what has happened India has done a wonderful job of making kind of a generic which are affordable and equitable at almost 100% same bioequivalence at 1% of international cost. And that's the reason that currently almost 92% of the people in the world with HIV infection, they are taking Indian medicine. However, this kind of research has not been done in diagnostics. So we don't have CD4 tests, we don't have viral load which are generic. Or if they are generic, then they are not equitable with the gold standard. So we need to do a lot of research in those fields. Fortunately, we have a very good and dynamic Prime Minister who has put tuberculosis as top priority, and he said that whatever you want, come to me, I will provide to see that tuberculosis is wiped out from this country and from the world. So with that kind of initiative, there's a rejuvenation in the program of tuberculosis and HIV. Now, the issue is tuberculosis has been a well-established national program for many years. It has very good infrastructure. HIV infrastructure has started only in last 10, 15 years, 20 years. But if these two infrastructures and these two infections combine, then we can have a very powerful fight and powerful journey together. And we have been telling for a long time that you cannot have a vertical program for tuberculosis and HIV and hepatitis B and hepatitis C. You have to combine these kind of energies. Initially, it is very good to have a vertical program to get required attention. But once the program is well established, then it is duplication of efforts, duplication of manpower, duplication of offices, duplication of kind of national program officers, state program officers. If you combine, then you can have at less cost double the strength available. And that is being done to some extent where tuberculosis treatment is being offered at HIV treatment centers, and HIV treatment centers also combined with the RNTCP program. But they need to be combined more and more efficiently, and that is not happening. Now look at some of the issues where in tuberculosis we face problem with extrapulmonary tuberculosis. In HIV, almost 40 to 50% of the tuberculosis cases are extrapulmonary tuberculosis. And a lot of people do not have that clinical acumen to diagnose them. Even if you diagnose clinically, you cannot test them with laboratory because a lot of tests are very difficult to do. For example, if there's somebody is having a serious tuberculosis, so doing a CSF examination, doing a lot of kind of brain biopsy or some kind of tissue biopsy, it becomes very difficult and expensive. However, treatment of tuberculosis being cheaper, it is affordable. And currently, RNTCP program, that is our revised National TB Control Program, is providing entire treatment structure free of charge for all over the country. And there are several outlets for the tuberculosis treatment. Now, with newer drugs being made available, but only at the programs, national programs, it is becoming easier to some extent to treat even the MDR and XDR tuberculosis, but that still remains the challenge. And the death rate has been very high in MDR XDR tuberculosis. So we would like to combine our efforts also with the societies like International AIDS Society. There's a IAS and ASI. The words are almost the same, but we are in India. We are a small organization of only one nation. International AIDS Society is a very big or large organization. If we combine our efforts together, I think we can do a great job. And I'm really glad that Dr. Linda Gale being in South Africa, we being in India, we have a freedom struggle together for many years earlier. We can have freedom from tuberculosis and HIV struggle also together. And I think by doing this kind of World AIDS Day or International Human Rights Day, they will become more and more significant and important only if we combine the efforts. Otherwise, they will become only tokenism. You have only remember these decisions only on a particular day and forget about it. Thank you very much.
Thank you very much. That was one of India's leading AIDS activists, Ishwar Gilada. Before we open the Q&A session, let us listen to the most important voice on the panel today. We believe voices of affected communities must be critical, must be central in responding to the epidemics. Nama Ampondo Barnabas, a TB survivor and person living with HIV, and Civil Society Liaison Officer, International Union Against Tuberculosis and Lung Disease, the Union. It's over to you, Nama Ampondo.
And Noma, please unmute yourself.
Okay.
Yes,
Can
we
you
can
hear
hear
me?
you. Yes, yes,
All
we can.
right. Hi. Good afternoon, everyone.
Yes.
It's always a privilege for me to be part of this this webinar. It's not for the first time, and thank you so much to CNS for always thinking about me. And I've heard Professor Gail Baker talking about ambitious figures. And what I'm trying to do is to really put reality to the whole webinar of today. One of what I want to bring to the table is the important agency of TB and HIV scientists to work closely with CSOs, to work more closely as partners in order to try and achieve those targets, Professor Gail Baker. But what I really would like to share mainly on a personal perspective, which is sometimes also is common, which I've heard with my other fellows who have been impacted by both conditions, since we're talking integration because we are seeing numbers of co-infection. The issue of pill burden is a huge challenge, which sometimes can be as a result of loss to follow up, as Professor Baker mentioned earlier. Pill burden is actually quite a huge challenge. When I was infected with both HIV and TB, I had to take 13 tablets a day. It was my 5 TB tablets. By then, because that was again before we have a fixed dose of ARV combination, I had to take 5 ARVs. I had to take 2 antibiotics. I had to take what's this? Please remind me, doctors, paradoxin to prevent peripheral neuropathy. So if we can, as we move forward with this, all the efforts that we are looking of trying to combat HIV and TB, we need to look at improved regimens that are tolerable with less side effects. And what I also would like to bring to this table is the issue of the countries which can easily adopt WHO and other universal guidelines. And yes, those policies, guidelines will be translated into country policies, but then the challenge will be implementation, where you will find reasons like funding, we don't have funds, we still trying funds. And for me, really, the diseases are not in recession. So always talking about funds, it's not going to help at all. We need to, once we adopt those guidelines as countries, translate them into policies, fine, but we need to make sure that they are implemented and taking them to grassroots level. I liked one of the slides that Professor Baker shared earlier, issues of PHC, primary healthcare facilities, because this is the first level of where the community goes to when they seek help. So we need to translate most of the practices down to PhD level. And what I also would like to bring to, and one of the challenges is that why it's important goes down to PhD is we know that most of the population they are both socially and economically challenged. So for them to get to those high-level health facilities becomes a huge challenge for them. What else I would also like to talk about, one of the missing links, which also has come up from the civil society gatherings, was the issue of disabilities in TB. We talk now diabetes in TB, which is fine, but we have seen people losing their hip, they're taking their MRT, their MDR drugs. We have had people who have suffered TB of the spine and upon wheelchairs. It's something that either research or whoever works in the field of TB to look into disabilities of TB. Even within the union, I have brought that up, that we need to start discussing it and bringing to the table. which again would talk to the issue of improving TB drugs, more especially around MDR TB drugs, which affects the hearing. And there's one lady from, I can't remember which country, who has lost her sight because of MDR drugs. She has attended 2 union conferences I've met with her, and she's always accompanied by her husband. So these are the things that we need to try and unpack as we move forward with all the targets that we are trying to raise forward. And we need to also not look at just the statistics and the figure. We must remember that we're talking about human beings here. Yes, we need to try and reach so many, but let's not reach the target, let's not trust the target, but let's put the human face and human perspective into the whole thing and try and address, come up with holistic approach to try and combat the disease and reach our target. I think for now that will be it. Maybe again, one is Obi mentioned the importance of including the voices, and this is one strength that I brought to the union, because I've been involved in the HIV field as far back as 1997. And I've seen people with HIV doing the tide around. It was until people with HIV stood on the front line and said, this is what we want to see happening. And we need to do the same even with the TB society. Also hear voices and hear what their challenges are, what their issues. So that's right for now. Maybe then when questions come up, I'll respond.
Thank you very much. That was our final speaker, and now he's back. That brings us to the end of the expert's presentation. Now let us begin the open session. Participants, please keep sending your questions using chat function or raise your virtual hand on the webinar screen. Its open session begins right now.
Thank you, Ashok. We already have a lot of questions pouring in. The first question is for Dr. Linda Gail Becker from Bangladesh. Zafar from Bangladesh wants to know. He says it is alarming to know such a large number of our population has latent TB infection, and 1 in 10 of them may develop active TB disease. This means huge new numbers of TB disease cases in high burden nations where latent TB rates are skyrocketing. How to avert this? How to avert latent TB not converting into active TB disease?
Yeah, so those are excellent questions, Shoba, and I went through that so quickly that I'm really impressed people got the gist of it, and I'm sure you'll make these slides available to people so that they can think about it afterwards. But I think 2 important points get raised from this. The first is absolutely right. Unless we start to have an impact on latent or infection, so the fact that so many people are being exposed to TB at a young age is the concept of the upstream intervention that we need to think about. How do we stop people getting infected in the first instance? And as you know, our only vaccine, namely BCG, does not seem to protect against that. So, one, in the long term, much like HIV, we need to think about a better vaccine. But failing that, what are some of the structural interventions that we can do to prevent young people, because it's predominantly young people, who get infected at a young age and then become the sitting ducks, if you like, for active TB disease that may come on either immediately. So we know that some people go immediately on to active disease. For others, they need to hit diabetes or get old or be nutritionally compromised, or, of course, have their CD4 count drop because of their HIV infection. And then those individuals go on to have active TB disease that requires treatment and, importantly, becomes a source of infection to other people again, and so completing the cycle. So the first point that I think is raised by this listener is, one, we need to intervene on that large pool of latently infected individuals? And then secondly, how do we prevent people going on from latent infection to TB disease? And surprisingly, there isn't a great deal of research about this or knowledge. I think there's increasing interest about those biomarkers, what helps us to figure out who's going to go on to TB disease. But that hasn't been known, despite the fact that we have known about MTB. Robert Koch discovered TB 130 years ago. So there are some real research gaps. And that brings another plea through this webinar, is that we have to have ongoing research, because there's a lot we don't know about tuberculosis. So I think this is another important area of research, is how do we identify those who are most at risk for going on to TB disease, and can we intervene more quickly in those individuals? Certainly HIV is a very obvious risk factor for going on to TB disease, and that's why making HIV doctors and clinicians more aware about TB and making TB people more aware about HIV is a very obvious intervention to do.
Thank you. Thank you, Dr. Becker. Participants, please keep sending your questions using the chat function, or raise your virtual hand on the webinar screen which you see to ask yourself. We have a question from James Sandstrom. James, would you like to ask your question yourself? Would James like to ask the question himself?
Oh, this question is for Dr. Becker.
Yes.
In the early 1900s, New York City ran very large public education programs to educate the public about TB transmission. They did these at football games and theaters and all sorts of approaches to educate the public. Would such approach or a media campaign work in Cape Town to help with the generalized epidemic?
So James, you raise an excellent point, and again, thank you for picking up on what I rather ham-fistedly was hoping to do, which was to show that places like New York, and indeed large parts of Europe, brought the TB epidemic under control long before the discovery of streptomycin, which is our first anti-TB antibiotic. So I think the notion that we have, and I worry that we're falling into a similar sort of paradigm in HIV, is that we can treat our way out of an epidemic. So all we have to do is throw more antibiotics at something and it'll mysteriously and miraculously disappear. Well, clearly, New York brought their epidemic under control without any anti-TB therapy, but did a bunch of structural things. So you raise public awareness as one option, but I know they also, passed the Tenement Act. Every building had to have a TB window. They separated those who had TB from those who did not. Now, that has some human rights implications, but certainly there are lessons that we can learn from those 1900 interventions. Rikers was rebuilt. Big hostels were taken apart so that you did not have large people exposed to potential infectious cases in unventilated venues. And we have forgotten all those lessons, and we haven't applied them in the third world, and we've become somewhat infatuated with just treatment. And I think what I was hoping in a somewhat provocative way this afternoon was to raise the fact that we should not forget the structural, the behavioral, what, Namapondo raised so beautifully, the human rights side, making sure that patients and clients are engaged in this process so that we come at this in a multi-pronged approach. And so, I think increased awareness is always a cornerstone in our public health interventions, and so I would advocate, yes, that is very important. There was a time when there were there were window monitors in classrooms. So when carbon dioxide levels got to a certain level, you would open the windows and increase the ventilation. We are now, increasingly educating young people in tiny, crowded, poorly ventilated spaces, and this may well be feeding into our latent infection population. So I'm hoping this afternoon to have just raised, in a provocative way, some other ways of thinking about TB.
Thank you. Dr. Gilada, would you like to comment on that? We would like to listen to your views on this.
Yeah, basically we need to have a really very big and large campaign, and not only for particular day or particular occasion, but for all around the year. However, in developing countries, there are other issues which are more important. Survival issue is more important. Roti, kapda, makan means the eatable, cloth, inflation, they are more important than diseases. And therefore, that's one of the reasons that people neglect, they don't go to doctors easily, they don't go to doctors earlier. So they are diagnosed as late cases, and that's the reason that they suffer a lot. Sometimes they succumb to the infections or diseases. We need to really focus on these kind of issues, and I would like to appeal Dr. Linda Gale Baker that we should not lose one single opportunity of fighting such infections, for such diseases together. And there is a saying in Hindi, "Ghayal ki gati ghayal jane aur na jane ko hai." Only wounded person know or understand the suffering of other wounded. And here in this case, India is one wounded and South Africa is another wounded. So we can understand each other's feelings, each other's philosophy, each other's limitations much better. So if we combine our forces, I think we can overcome. We cannot totally wipe out tuberculosis or HIV. They are wishful thinkings. We do make targets. They are going to remain, but we can overcome a lot of issues and a lot of problems related to HIV and tuberculosis if we work together.
Thank you. Norma, what do you think? What worked in New York in the early 1900s? How can we replicate that model, particularly in the third world countries where TB is such a big menace these days? As a community person, how can we replicate it?
I think, as I mentioned earlier, that I come from the HIV field, and we have learned a lot from the American strategies, and we have tried to apply them, and we have seen them working. But again, some of them really, sometimes it's usually due to funding. Sometimes we're not able, because most of the strategies that we have learned from the community perspective is advocacy and advocating for our needs. But sometimes we always find very limited funders who are interested in funding advocacy. And we have seen, in terms of programs, we have seen in South Africa, and Professor, I'm so used to call her LGB. we received a lot of support from PEPFAR, which really assisted South Africa. So I can say we have learned, and we can still learn and apply their strategies and efforts.
Thank you.
So, Shoba, can I just intervene briefly, just to say to Namapunda that, I appreciate, I think I would hope that the lesson we would learn is not so much that we have to emulate New York per se, but I think the point I was trying to make, and I think you picked up on that, is that we've got to broaden our thinking beyond just treatment. And you come from an HIV world the same as I do. And I think the message also in HIV is let's not fixate on the treatment, although treatment is key. I showed you the 90-90-90. We want to do that. But we mustn't do it at the exclusion of primary prevention and structural interventions as well as human rights. So that was the message that I was hoping would come through, that we want to go beyond just pills.
Thank you.
Okay.
We have the next question is for Dr. Gilada.
Yeah.
Dr. Gilada also comes from the HIV world, where he began HIV care among first doctors in India. But then today, all the TB and HIV world, we are trying to bring them together. Dr. Gilada, there are two questions for you. The first one is from a journalist from Pakistan.
Hello.
that, sir, you head the largest network of HIV specialist doctors in public and private sectors in India. Is rational treatment in private sector for TB posing a challenge in India?
You're talking about tuberculosis treatment in private sector.
Yes.
Yeah, it has been challenged because what has happened is tuberculosis treatment was going on well. In between, DOTS therapy came. DOTS therapy was so confusing that you take medicine on alternate days, that is 3 out of 7 days, and then we realized that DOTS is failure. It's a great failure in HIV patients with tuberculosis, but otherwise also it was failure. It was failure because of 2 reasons. One is, anyway, as a human tendency, people in India were not adherent, and they were anyway taking like DOTS. When there was a regular therapy, they were taking like DOTS. And if you are giving them DOTS, then they will, if they skip one dose, they are skipping for 5 days. So suppose somebody is taking Monday, Wednesday and Friday not taking, and taking next Monday. So after Wednesday, it is after 5 days he is taking the drug. And that was a great failure. So private sector, they could not cope up with the initial regular treatment, then DOTS, and again now it is regular treatment. That was one reason. Secondly, tuberculosis, being as Dr. Linda Gale-Baker very nicely put it, it is spread through the sharing air, whereas HIV is spread through sharing the bed. When you are expected to see that people will share the air, lot of private sector people having lot of overcrowded clinic wanted to avoid tuberculosis patients in their OPDs, and therefore it was being treated only by tuberculosis specialists or chest physicians. Even today, in a city of Mumbai, not single private hospital would like to attend would like to admit MDR TB case. Not a single. There is not a single exception also. So ultimately, MDR cases, XDR cases, they will become piled up only within the public sector. And that was one reason, that because it is started transmitted through air. What we would like to tell people, particularly lay people, that if a patient of tuberculosis, open coughs, tuberculosis positive, take even a first dose of treatment, 80 to 90% of bacilli load goes down. They become non-transmittable by 80 to 90%. And therefore, we need to tell people that those people which are on treatment, they are less dangerous than those people which are not even diagnosed. And that message has to be given very loudly and clearly. And somehow, private sector will be now roped in, because RNTCP has decided to shake hands with private sector. They are providing not center for diagnosis, facilities for diagnosis, facilities for treatment free of charge, even at kind of private doctors' clinics. So there are some of the organizations which have already started, and they are networking with a lot of private clinics, and that is happening very nicely.
Thank you. Participants, please keep sending your questions using the chat function, or raise your virtual hand if you want to ask the question yourself. We have Dr. Gilada, the other question for you is from Rahul, who wants to know that you were right in saying that India is a pharmacy to the world when it comes to TB and HIV. But drug stockouts are a reality in India today. Please share how to resolve this, as Indian government's national health policy commits to end AIDS and TB too. How can we resolve this issue?
You see, as an organization, AIDS Society of India, we are partnering with NACO, National AIDS Control Organization, as well as RNTCP. And we are telling that our members are at your service. Wherever you find our services can be utilized free of charge, we are available. There are problems and issues with drug stockouts, mainly because of some reasons, like HIV treatment guidelines change quite frequently, more frequently than the seasons in the country, seasons in the year. It was 200, 350, 500 not test and treat. However, our political commitment, or health minister has given a statement that we will go by test and treat strategy. If you go by test and treat strategy, there are 400,000 or 500,000 more people to be added to the treatment. If we are not able to meet the challenges of 1 million people on treatment, by adding another 500,000 people, will be creating more problems. So first we need to tone up the administration of drugs or drug stockouts issues, etc., or diagnostic issues, or viral load testing, etc., for those 1 million people, and then we should keep on adding other people, which are anyway healthy. They are not. I'm not saying that we are against test and treat policy, but we should be slowly going towards that issue but mainly going fast on the other issues where diagnostics are not properly in place. We are talking about 1990. The third 90 in India is so weak that we have out of 400 ART centers in the country, only at 10 or 12 places there is a viral load facility. 390 places there is no viral load facility. So if viral load testing is not there, how can you talk about third 90? So this third 90 is so weak in the absence of viral load. Now they are going to procure. So before you have to procure machines, have the technicians in place, and then you increase your workload. By doing only increasing workload, there will be mismatch. And the other issue is only 4 states in the southern part of the country and 2 in the northeast they have a high HIV load. Other places they don't have much HIV load. So when the drugs are being distributed, they should take into account that these 6 states will require more drug supply, other places will require less drug supply. That has to be also properly plugged in. So some of the management issues are there, but probably they will be solved in sooner than later.
Okay, that's very positive and hopeful what you have said. We have a question from a journalist from Indonesia for Noma. She says, Noma, you brought up a very pertinent point about the role which communities can play. So what role can communities play so that governments roll out new treatments without delay? The shorter MDR TB regimen of 9 months is yet to reach most people who are affected by MDR TB. 1 in 5 MDR patients get treatment anyways, which is abysmally low. Please share insights on how can communities help in getting the treatment regimens which are available reaching the populations who need them most quickly. That
Okay.
there is not so much of a timeline.
Okay, for me, quickly, the advocacy plays a huge role here by the society themselves making noise. As I said, that I learned from the HIV field. And secondly, in terms of, now that I'm with the union, I've seen a lot of presentations for the community track, where the communities play a huge role in finding what we call it active case finding, because they are in the community, they are hands-on, they see those who are infected by the disease. Key for me is helping to identify and refer those who need help. And secondly, advocacy. And my advocacy is 3 A's: is accessibility, availability, and affordability. It doesn't have to say we have a drug which is not affordable, which is not accessible, which is not available.
Thank you. With that, we come to the end of this webinar today. My heartfelt gratitude to all the panelists and participants for taking part in this webinar and enriching it with their valuable inputs. Special thanks to the International Union Against Tuberculosis and Lung Disease for helping us host this webinar. The webinar recording along with the slide presentations will be made available to you, all of you, as always. And lest we forget, World AIDS Day is on the 1st of December. Let us renew our resolve to scale up TB-HIV collaborative activities so that premature deaths due to TB among PLHIV, that is, among people living with HIV, can be averted and lead the way to end AIDS and TB both by 2030. Goodbye and have a nice day.
Thank you.
Thanks. Goodbye, everyone.
Bye, everyone.